Welcome to another session of Pulp Nonfiction. Today I have with me Dr. Bill Seddon of the UK. Bill got his dental degree 15 years ago, was it in Sheffield?
No, nearly 30 years ago,
30 years ago.
1990.
Pardon me, you worked as a general dentist for 15 years
Yeah,
and then limited your practice to endo in 2005.
correct.
And your office is in
I'm in Sheffield, in the
Sheffield
north of
still.
England.
Yeah,
Yeah,
yes.
yeah,
Yes, and bemoaning the suspension of the rugby league season, I imagine.
correct.
Yeah.
Yeah,
So what we would like is start off with some background information as to the current situation in the UK, and then we'll take it from there.
sure.
Yeah. Oh, sorry. Before we go into that, a little more bit background on yourself. What are your special interests in endo, and what brought you to endo in the first place?
So what brought me to endo? I first worked as an associate dentist with a colleague who was a really good endodontist, although he wasn't called an endodontist because back then we didn't have them in the UK.
Yeah.
So that was the early 90s.
Yeah.
And he took me to the British Endodontic Society's meetings several times, and I really enjoyed that. I then came across in the early 90s Cliff Ruddle, Steve Buchanan, Gary Carr. They all came to speak in the UK. I heard all them. I bought their DVDs, VHS even, I think, from Ruddle back in the day.
Mm-hmm.
Came over to the US to learn from those people. Bought a microscope, was already taking referrals, and then it just led. I was always very keen in postgrad education, looked at a lot of cosmetic type stuff, but my heart lay in endo. And so the opportunity came to limit my practice and become somebody who just did endodontics back in 2005. And that's what I've been doing ever since. And yeah, it's working really well until 2 weeks ago.
Yeah. Yeah, no,
Yeah.
absolutely. So the situation now in the UK, can you speak to that a little?
Yeah, I'll try and give a brief summation as what I understand. I was supposed to be away on vacation 2 weeks ago in France skiing. We had 1 day skiing. France then became locked down at midnight, and we drove back to the UK and arrived back on the Monday, at which point more and more concerns were being expressed about coronavirus. I wasn't due to see patients that week at all. I then spent quite a lot of time looking at guidelines, at regulations, and what was happening in the general world in the UK in that week, looking at advice from the British Dental Association, the General Dental Council, and the Chief Dental Officers for the NHS for England, Scotland, Northern Ireland, and Wales. They're all separate bodies. And nothing really concrete came out in that week. There was a little bit of advice that was that maybe we shouldn't be treating patients with active COVID-19. But at that stage, 2 weeks ago, we didn't have as much of it as we have now. A lot of people were still going to work and carrying on as routine throughout that week. Then we had more guidance came on later that week. So this is a week and a half ago, that we shouldn't be treating patients with active disease. I looked at guidelines then from the American Association of Endodontists, who were pretty specific in we should only be treating emergencies and or urgent cases. So that's what I decided I was going to do when I went back to work the following week. So that would be like a week ago when I was scheduled to go back to work.
Mm-hmm.
During that week, I think people started to see less and less routine patients. My referrals dried up to zero, basically. So in the last 2 weeks, I've had zero referrals. And that's not an exaggeration, it is literally zero. We had guidance from various bodies late on in that week, on the Friday, that we should be avoiding aerosol generating procedures whenever possible. We would be allowed to still continue to treat routine cases so long as we didn't generate aerosols. So we were having people in the practice I work, there is a general practice as well. They were still seeing people for routine recalls, for scale and polishing, but without using ultrasonics, and for emergencies as well, trying to avoid aerosols wherever possible. Over that weekend, the British Dental Association started to come out with more and more guidelines that aerosols should be avoided more and more so. And then on the Monday, I think I had a note from another one of the regulatory bodies to say we shouldn't be treating anything except for emergencies. So that happened about a week ago. And then I'm just trying to get the data in front of me. The Chief Dental Officer for Scotland came out with something more specific, as did that for Northern Ireland. But for England, it took another 2 days for them to catch up with the same guidelines. And their guidelines were basically don't see anybody for emergencies where you have to generate an aerosol at all. So the state of play at the moment is that we are, and this is in general in dentistry in the UK, nobody is seeing patients face-to-face anymore at all.
Okay, no face-to-face. Yeah.
So that changed from advice from, again, the British Dental Association late on last week, and also from the Chief Dental Officer. So the Chief Dental Officer for England came out with advice to say, that all routine, non-urgent dental care, including orthodontics, should be stopped and deferred until advised otherwise. All practices should establish independently or by collaboration with others a remote urgent care service providing telephone triage for their patients with urgent needs during working hours and whenever possible treating with advice, analgesia and antimicrobial means. They then went on to say, if the patient's condition cannot be managed by these means, they will need to be referred to the appropriate part of their local urgent dental care system. And these new arrangements will involve providers working with defined groups of patients to manage urgent dental care needs in specific centres. So I've had some private correspondence with dentists involving setting up these centres. As far as I'm aware, they don't yet exist. They're waiting for the PPE. We had guidance from the British Dental Association earlier on in the week, I think on maybe the Monday or the Tuesday, to say we shouldn't do any aerosol generating procedures without what we call here an FFP3 mask, which I think is a little bit like the N95 mask in the Americas, but more substantial than the N95 mask. And we basically can't get them. They're not available to buy anywhere. Nobody has stocks of them. People are looking at 3D printing of these sort of things, etc. But I'm told that the centres are almost ready to go, but they haven't got the PPE to be able to stock this, to be able to start running the centres. So the general practices now are basically closed for anything other than telephone advice. So the patients with problems, I don't know what's going to happen to them. It's a terrible situation for the patients. They're going to end up in hospitals because at the moment there isn't anywhere else for them to go. And the hospitals are already stretched to almost capacity, and the last place these people who are healthy with toothaches, etc., need to be is a hospital with a lot of ill people around them where their likelihood of contracting the disease is greatly increased. So I hope that these centres get set up really, really quickly, and I hope that the protocol that they use to triage the patients is robust. The British Endodontic Society came out with some really, really good protocol midway through the week, which then had to be changed and adapted because of the new guidance from the Chief Dental Officer. So the British Dental Association midway through the week was saying, this was on the 23rd of March at 11 a.m, that the procedures we had to do were to display posters in the practice to say that we're aware of COVID-19, etc. Update your websites. Don't treat anybody who has signs of the disease. So look at people's temperature. Same if there was anybody in the same household with the disease. To cancel all routine stroke elective procedures. Endodontic care should not be delivered in the primary care setting to patients who have symptoms of the disease. And then the cases that were then proposed to be treated were going to be cases with acute soft tissue swelling due to a localized dental abscess, cellulitis indicative of a spreading soft tissue bacterial infection that could potentially compromise the patient's airway and cause elevated temperature, acute dental pain, indicative of a symptomatic irreversible pulpitis, tooth fracture resulting in pain or causing soft tissue trauma, dental trauma causing avulsion, intrusion or lateral luxation injury, or replacing a temporary dressing in endodontic access cavities in patients with acute pain, which I thought was a really good list. I thought that was specific to people, so people could absolutely know whether that was appropriate or not. However, when the guidelines came out that we could only do aerosol generating procedures with an FFP3 mask, etc., nobody was prepared to do that in practice. And those guidelines then changed 2 days later from the BAS to say we should only be giving advice of analgesia and antimicrobials, and then urgent care has to be referred to the local urgent dental care centre. And then it goes on to say details and setup of these centres are yet to be finalised, but will incorporate the latest evidence-based PPE and treatment protocols. So it's a confused situation, really confused situation. There's a lot of dentists quite rightly concerned about the financial implications of all this, because we don't know how long this is going to continue for. There's little help available from the government financially, and these people may not have practices to go back to in another 8 or 9 weeks' time. They may not be viable at all. So it's really concerning to me what's going to happen to dental services in the UK. I work purely in private practice. I don't work with the NHS. There basically hasn't been funding in the NHS for endodontics for 15 years in the UK. It's a really confused system, far too much to go into in the time we've got today. But there's talk of dentists with an NHS contract being redeployed in the hospital settings as well to help with the COVID-19 crisis. We have, I think, close now to 800,000 volunteers, not from dentistry, but in the public as large, prepared to help out with the crisis. Dentists, staff from dental offices, I think are going to be pretty useful in that, because they've got experience of dealing with healthcare matters, etc., and we'd be quite valuable for that. I've certainly spoken to the people who I know arranging these access centres about, please, I will help you out, let me know what to do, because I think it's going to be better for somebody like me to be opening teeth up than somebody that doesn't do it all day long. We're going to get it done faster for the patient, minimise contact time, less aerosol, etc. But I've heard nothing back. So I'm here and willing to help. But I almost feel that there's some people who seem to know what's going on and other people that don't. So I've been talking to a lot of dentists today, and their practices have said, well, we know what the next stages are. And other practices say, we know nothing about this at all. Some practices have been trying to work a little bit and do emergencies. Some practices shut down a week and a half ago. It's confused, and we're lacking direction and leadership. The General Dental Council here is the body that regulates dentists and keeps their registration. So if you aren't registered with the General Dental Council, you're not allowed to work. So I looked at their website, and it only got updated towards the middle of last week. And their statement was, we don't expect any dental professional to provide treatment unless in their professional opinion it is safe to do so for both patients and the dental team, which I thought was passing the buck a little bit. I think it was putting the decision on the dentist rather than giving a true statement as to what we recommend and what we don't recommend. The chief dental officer said, we expect the profession to exercise clinical judgment in applying this guidance. No one will know your patients and your staff better than you. So again, it's maybe not doing what I would like it to do, and to say, really, for the good of mankind, we should be limiting completely what we're doing at the moment and making sure these centres are set up correctly and set up safely so that we can work in a safe environment to stop these patients that have got undoubted dental needs ending up in hospitals. The general public know nothing about this at all. So I was looking on a skiing forum, and the chat came around to dentistry, and nobody knew that dentists weren't allowed to work anymore in the UK.
Mm-hmm.
No, they all thought it was just as normal,
Mm-hmm.
and were maybe just emergencies. But there's been very, very little on the news, etc., about dentistry. It's all been about medicine, which is probably quite right. But I know a lot of general dentists are feeling very left out, very hard done to by the authorities at the moment, in that they're getting no funding, and they're being obviously advised not to treat any patients when they want to be trying to help those patients who they can help. So it's confusing, it's changing rapidly. No doubt if you were to speak to me at this time tomorrow, it'll have changed again, because I think we really don't know what's going to happen with the virus. But we've got to make sure that we do have a dental service in existence in another 6 months' time, because people are always going to need us. And we need to be able to offer that care to patients who have got significant swellings, etc., because it's not uncommon for us to be seeing that sort of thing in the line of work that we do.
Mm-hmm.
So yeah, it's a confused situation. It's a situation I think that we need leadership from. I know there's a lot of other dentists that I know are writing to their members of parliament about things. It's been brought up on a bill before Parliament about dental care, but didn't get anywhere. The British Dental Association have met with the Health Minister, although he now has COVID-19, so they can't meet with him anymore, to try and express that, we're still here, we want to help, but we almost seem to be being neglected from any of the negotiations. So, yes.
Is the British Dental Association, they're not, they're a sovereign body, they're not part of the NHS.
The British Dental Association are basically the trade union for
Yeah.
dental care professionals.
Right.
So they're not part of the NHS. No, they represent both NHS and private practitioners, as well as dental nurses, hygienists, therapists, etc.
So is it NHS chatting to the British Dental Association about the setup of
Yeah,
these
so the
centers?
NHS is the chief dental officers.
Yeah.
So yes, there is communication going on.
Yeah.
The British Dental Association have written some quite strong things to the chief dental officers to say, we need a statement from you,
Yeah.
we need you to do X, Y, and Z. And the replies back have been, to me, not strong enough. They've just been a little bit, well, we've already told you what to do, etc. And it's up to the individual dentist to make the call on whether they should be going in, which I think is wrong. The British Dental Association have kept their website pretty up to date. They've been putting things out there every few hours of every day, basically asking for clarity about things.
Well, is it officially you can't see patients in your private practice?
Whether it's official, I honestly don't know.
So it's a mixed
but
message.
The advice is certainly avoid face-to-face contact, avoid aerosol generation. I personally don't know any dentists who are working and going in to see patients at the moment. I've heard of patients being seen in the car park, so that the aerosol, well, just the respiratory droplets can be spread better and not contained in a single room, etc. But I'm not aware of anybody who is actually practicing in their practice at the moment.
So the preamble that you were chatting mentioned when we first chatting, when they were saying, don't see patients because we're going to set up these urgent care dental centers.
Yep.
Just don't see regular patients, but if push comes to shove and you have to see a dental emergency, you still can. But
now it's saying you should send any emergency that can't be treated by antimicrobials, advice, or painkillers. They should all go to the dental emergency centres.
Okay, so no face-to-face. Pretty much.
Yeah.
Okay.
So you're supposed to triage on the telephone, not actually in the office. So the practice I work in has been shut down. It's been mothballed since Wednesday. I personally rung all my patients for the future from home via remote desktop for the next 3 weeks to cancel all those patients and not been able to rebook them at all. They've all been very understanding of things. There isn't anybody who is urgent at the moment, probably because they haven't been able to see their own dentists to be referred to me, because their own dentists are not working either. So it's I don't know what's going to happen in the next week. Things are going to get probably acute with dental problems. People have managed for a week, but then things are going to get worse and worse and worse as they're not able to access care. From what I've read, Northern Ireland is a lot smaller than England. They're setting up 5 of these centres in Northern Ireland. That's it. So
Population of what is it? 3 million?
I'd have to. Yeah, you probably know better than I do. But yeah, I would have thought something like that number. So what it's going to be in the UK, in England, I honestly don't know. I honestly don't know. I don't know where they're going to put them. It would make sense. I would have thought to put them in the dental hospitals, of which we've got about 10. Yeah. So it's still not a big number, and there's a big distance between a lot of places. So maybe some of the community clinics should be used as well. People are working on it, and they're working really hard on it. But I've not been told. So I don't know. I'm just sitting and waiting like a lot of other dentists are.
Is there a clear list of COVID-19 symptoms? Because that's one thing I think is, don't show active symptoms. Well, what are the active symptoms? Do they have a clear list?
The government have come out pretty well with that. Yeah. Not just in terms of dentistry, but also in terms of just in general as well, because we're all having to stop at home now, etc. Yeah. And if you do have the symptoms, you're supposed to now self-isolate for, I think it's 2 weeks if you have symptoms, and anybody else in the household has to do the same as well.
Are you familiar with any list of symptoms?
I'll have to look it up, Joel.
Okay.
I think they were talking about cough, fever, and a temperature over 37.8 Celsius.
Yeah.
Off the top of my head.
Yeah. Another big one that I heard was lack of smell.
Yeah, the smell and taste. That's been talked about on the news here as well. Yeah. So.
Yeah.
Yeah.
And some of the doctors have said sometimes the first signs is diarrhea.
Okay.
Yeah. So I was just wondering if you're privy to an actual list, because I
haven't seen that. No,
I've been scrambling myself because everyone's thinking cough and sneeze, but
sure.
Yeah. Well, how do we actually spot it? That's quite interesting that they want you to direct the patients to these centers, but these centers aren't set up, so there's a bit of a lag.
Yeah, absolutely. Well, I got communication about the centres, I think, last Wednesday. I sent an e-shot to all my referring dentists on Monday to say I'm not treating anybody except for emergencies. We will follow all the guidelines, etc. And as a result of that, I got an email back to say, please don't use any aerosols. The evidence is really strong about this, etc. And then basically within a few hours, the advice came out that we shouldn't be treating patients with aerosols unless we had the FFP3 mask, which I don't. So I then decided at that point that I couldn't treat anybody. And then the advice became stronger 2 days later. So I then sent another e-shot to my referring dentist to say, I'm very sorry, we can't see anybody now. You'll have to direct them to the centres. And again, I got supportive replies back from referring dentists. But again, nobody seemed to know where these centres were going to be. I was told they were going to be set up by the weekend from one of my referring dentists. But that's all I've heard, and I haven't heard any since. I presume they're so busy working on it that they haven't maybe got time to keep everybody in the loop until it actually happens.
Yeah. Now, do they have enough oral surgeons, dentists, and endodontists for those centers? Like, I'm surprised.
I don't know who's going to staff them. I don't know whether it's going to be oral surgeons and endodontists, because in general, we haven't got many in the UK. There's a reasonable number of oral surgeons who are within the NHS system, because most of our hospitals have an maxillofacial surgery department, stroke oral surgery department, but endodontists in the NHS system, very, very few. Yeah. Very few. So oral surgeons, we should be good at, if they can be redeployed from the hospitals. I presume they've all thought about this, but I don't know. I've not been told.
Yeah. Now, for you with teledentistry, let's say you have a referral from a dentist and the patient's in pain. Here, they're relaxing the rules. I'll be able to diagnose over the phone. Okay. I'll be able to accept the medical history via email, and I'll be able to phone in a prescription without a clinical examination. Okay. So is it similar?
I think that's going to happen. I think there's going to be relaxation of the rules with that, from what I've read from the General Dental Council.
Yeah. Now, symptomatic irreversible otitis, there's a method out there that's untested, and I've used it once, And I'm just wondering if you're familiar with it, like a high dose of dexamethasone for
So the
24
one from
hours.
Gas and Yared, is that the one?
Yeah, that's the one.
Yeah, yeah. I've been reading about it in
Yeah,
the last week. I hadn't heard of it until then.
me too.
So I have no other experience other than what I've read in
Yeah,
the last week.
yeah,
Whether other people in the UK know that or not, I don't know.
yeah. Because you don't want to be a cowboy and put
Yeah,
someone at risk. I've talked
yeah,
to my medical professionals, and as long as they're not diabetic, because their sugar levels are going to go up, as long as they're healthy and not pregnant, and they have absolutely no signs of COVID, a short 24-hour burst of steroids isn't
yeah.
necessarily going to be bad.
Okay.
Um, you
So
know,
few dentists will have dexamethasone in their practice. Um, so it's going to be, how do we get hold of this as well?
you don't phone it into the pharmacy.
No,
Ah,
very, very rarely.
oh, okay. So you dispense medications.
We dispense, yeah. So if I need to
Uh,
give antibiotics, we have them in stock in the practice of
oh,
the
okay.
common antibiotics that we use. I have once written a script for some steroids for a patient who was actually from the US, who was a nurse practitioner, who
Yeah.
was really wanting the steroids, etc.
Hmm.
But it was so difficult to organise it with the pharmacy, she didn't end up taking them. So it's not a common thing to do here at all.
Huh.
And because
Oh,
I'm a private practitioner and not NHS,
yeah.
my prescriptions are slightly different. So the NHS prescription system has a
Hmm.
flat rate for a prescription cost for a patient.
Hmm.
I can't write an NHS prescription because I don't have a contract number with the NHS. So I have to write a private prescription, and a
Hmm.
pharmacy will charge far too much money to fill that prescription. So that's why we stock the drugs ourselves.
Uh,
And I basically don't charge the patient to give
give
the drugs.
narcotics in your office?
Do we have narcotics? No,
Yeah.
no.
Okay. So what do you do if you come across that? Then they go to the chemist?
If we need to, yes, we can write a private script for that then. Yeah,
Okay.
yeah,
Okay.
yeah.
Okay. Yeah. It's the opposite now. There's so many rules and
Okay,
restrictions on dentists having, well, in Canada, any
yeah,
drugs in their office
okay.
that
So
it's so
ours
not.
are all locked, etc. And
Oh yeah, yeah. We have to check it each day, and
yeah,
it has to be two people, and you have to sign off on it.
okay,
And it's such a song and dance. So forget it.
okay,
The pharmacists are wonderful people, and we have the
great.
Pharmanet where they can look up what there is. So it's like I have no reason to have anything in my office.
Yeah, that sounds like something that we need to look at, doesn't it? Then, because it sounds a much better system than what I have to do.
Yeah, yeah, yeah. And we don't necessarily get paid for the prescriptions, which is kind of nice because then you just like you need a prescription, and
Absolutely. Yeah, yeah, yeah,
go chat to the pharmacist.
yeah,
But
yeah. Absolutely.
huh. So going forward, I
Yeah,
guess yeah, the private practices are closed, and it's going to go to these centers. And
yeah.
the concern here is, will the public system be robust enough to handle all the cases? So they're leaning a little bit more on the private practices to basically keep the dental patients away from the public system.
Yeah,
And
well, the high street practices are also NHS practices, so that a lot of high street practices in the UK are
yeah.
still NHS dentists.
Hmm.
What would concern me is I don't know who's going to be staffing these centres, and I don't know how they're going to cope with the volume because I don't know
Hmm.
how many chairs they're going to have, etc. And then what happens to the patient afterwards? Because the recommendation is now to have just a pulpotomy done in an endodontic case. So who's going to finish that treatment later on? If they're going to go back to their general dentist, will the general dentist finish it? Will they refer on to an endodontist? How busy are we going to be afterwards? Because I've got 45 patients I need to reschedule that I've had to cancel. And then I'm going to have the emergencies coming in as well. So looking forward, it's how we're going to fit all these people in. It's a huge amount of work for all the reception staff as well to try and reorganize patients. I've made the decision not to rebook anybody because I don't know when it's going to be. For me, it's easier to just do it once when I know when I'm going to be able to go back rather than have to potentially re-cancel patients again.
Hmm.
Um, and I don't know which practices are going to still be here in 8 weeks' time, because if they don't get any help in terms of funding for their staff, etc., we're going to be in a real mess. A real mess.
Well,
I'm lucky in that I only have one of the member staff to pay.
yeah.
And
Are
we
your
can survive
staff
for a short amount of time.
are your staff going on the dole?
Um, that's a really good question. And it depends whether you have an NHS contract or not, and nobody really knows the answer. So if you have an NHS contract, it is, I'm told that there's a scheme coming in, you'll be familiar with the word of furlough, but if you have an NHS contract, you can't use the furlough scheme, is what I'm told, because the NHS is supposed to help you out. If you have a private practice, you maybe can, but there aren't many people who have just a private practice. So are they going to have to go on the dole? Yes. However, if you are self-employed and you are a dentist or a hygienist who does really well, you're not going to get any pay, because anything over £50,000 UK in terms of a yearly salary, the government are going to give you zero. And the furlough scheme, they're going to pay 80% of normal wages up to £2,500 per month, which will help people survive if you can get on the scheme. So the dentists I know that are trying to get that up and running are having difficulties with it. There are supposedly going to be some what are called coronavirus business interruption loans. I haven't yet met anybody who's qualified for one of those. So it says you're going to be able to get this loan, but people haven't actually managed to get the funds down from the banks, even though the government have promised that's going to happen. So the people that have got the big practices with a lot of staff, they're really concerned, rightly so, because it's not been their choice to close.
Did you have office overhead insurance?
Yes, but it doesn't cover this.
Pandemics?
It doesn't cover this. Some people are finding that their cover does cover for pandemics. Others are not.
Yeah, because there's a big loophole there. Here, the insurance companies are able to deny it because the government's not banned dentists from seeing patients. You can still see an emergency patients. So the irony is if you're a general dentist, 99% of your billable procedures, perhaps 99.9% of your billable procedures, you're banned from doing. But you don't qualify for, and the government's banned you from doing it. But you don't qualify for pandemic insurance because that 0.1% dental emergency, they still want you to treat. And the government wants you to do that so that it keeps the person off the public system. And then the gentlemen in the Bahamas on the yachts are kind of laughing at the dentists.
I think it's such a changing situation, and it's happened so quickly that it's been so much for a government, etc., to think about. That things are going to move, things are going to change a little bit. And to them at the moment, dentistry isn't a priority. Keeping people alive is a priority, and helping this thing not get considerably worse is a priority, and I've got to agree with that.
But the dentistry, the good thing of dentistry is it could keep people out of the public system.
Absolutely.
Don't let it get, I have some colleagues up north in BC, and one of them has this, 18-year-old lad, and he needs 4 or 5 teeth pulled, these, low socioeconomic family. And the general dentists, haven't got the PPE to pull it. And so he's like, well, can we pull it in the hospital? And because they're too poor to go to Alberta, the next province, they're too poor to go to Prince George. And then, so can we pull it in the local hospital because you guys have the protective gear? And they're, and then you meet that medical wall. No, this is a dental thing. Well, okay, so you're going to wait till it becomes a fascial space involvement issue and then be heroes?
I totally agree. And that's what I was writing on my website and sending out to the referring dentist a week and a half ago, those exact same things, that we should be doing this to try and prevent these things getting worse, and putting
a stitch in time saves 9.
Sorry?
A stitch in time saves 9.
Absolutely. But that was taken out of our hands. Whether we're still allowed to do extractions in general practice, maybe. Maybe, I don't know. But we're even told we shouldn't be taking intraoral radiographs because of cough, etc. Not everybody's got a CBCT or a panoral machine, so we're going to do that without radiographs, etc. And what happens if you break a tooth and then you need to do a surgical extraction where you're going to use aerosol? So, people are looking to protect themselves as well as patients, which is understandable.
And to get staff to come into the office,
because now the staff to come in and risk the contamination, etc. I was told by one person that maybe in his practice he's going to have staff coming in for one day and then self-isolating for another 6 or 7 days, and then come back in again and try and do a rolling system through his staff.
I heard from a physician, and this might be a better way to go: work for 1 week,
Yep.
and then self-isolate for 2 weeks.
Okay.
Work for 1 week,
Yep.
and then have it that way, because that self-isolation for 2 weeks, hopefully the
Is
symptoms
enough.
will show.
Yeah.
Yeah.
Yeah. Yeah.
Yeah.
No, that would be. I mean, I've not. I've been basically self-isolating now for 2 weeks just because of we came back and my future daughter-in-law is a high-risk person anyway, so she's stopped at home. I've only been out literally to ride my bike and walk the dog, and that's it. So I've not come into contact with anybody at all. So I'm reasonably happy that I haven't got. Well, I know I haven't got symptoms. Well, do I have the disease or not? I don't know.
Yeah.
Absolutely, certainly, I don't know. So do I want to go and risk myself being exposed, etc., by going out in the outside world, so to speak?
Do they have test centers for healthcare workers?
We are maybe starting to do that.
Okay.
We're way behind.
Okay.
So even the frontline staff haven't been tested.
Yeah.
That was one thing that was mentioned, that dentists could be involved in that testing.
Mm-hmm.
So we could actually do the testing, which
Yeah.
I'm very happy to do. But at the moment, no, we haven't got the test. It would be nice to have the antibody test so that we can tell if we are going to be able to work. I don't know whether there's any benefit to actually knowing have we got the disease or not, if we have the antibodies against it. But then we're looking at the false negative rates on that of maybe 30% on some of the tests, which, you might as well not do it at that.
Well, yeah. So I was talking to some Canadian physicians, and they were saying patients come in and they test negative. And they came in for a herniated disc or a kidney stone or something, and the next thing you know, they're crashing and needing a ventilator, and that came out of the blue, like they're getting surprised, and so that false negative might be quite high.
Sure.
Yeah.
So you've almost got to assume that everybody has it.
Yeah.
Which is certainly the way I will be approaching things, and I don't know how it's going to change when we do get back to work.
Yeah.
Will there be masses of orders for rubber dam in general, etc.? Because the vast majority of people in the UK that I see for retreatments have never seen rubber dam before.
Wow.
And that's on the recommendations from the British Endodontic Society and the BDA for the aerosol generation to use rubber dam no matter what. But it's really uncommon here. It should be more than it is, but it's really, from my first-hand practical experience, it's way under 10%.
Wow.
Rubber dam for endo.
Yeah, I noticed that when I had my dental training at UBC in Vancouver, it was rubber dam land. Yeah. And rubber dam. Okay. And then even like crown prep, you take off the rubber dam right before you check the bite, before you take an impression. Yeah. But do as much as you can with rubber dam. Yeah. And then I went down to Texas to do my undergrad, my certificate for endo, and I was surprised the culture there. Yeah. The rubber dam was not nearly as prevalent. Sure. And it's like, whoa. Like when you go from rubber dam land, like, it's so clean, it's so nice, it's so everything.
Yeah, absolutely.
Well, what do you want to deal with saliva and a tongue for?
Yeah, absolutely. Yeah, I mean, it's something I've been very keen about for an awful long time. I've never done endo without rubber dam.
Yeah. Well, up here, if you do basically if you do an endo without a rubber dam, then you've got like no leg to stand on. Okay. It's a bit like running a skydiving company without parachutes. Like what's the point?
No, I've heard similar in the UK, but I don't have personal experience of that. But I've heard similar. So why people still do it, I have no idea.
Yeah. No, we're in for a big culture change and practice shock. Back in the 80s and the 90s, blood was seen as the potential avenue for disease. Yeah. Contamination. Now saliva. Yeah. And aerosols. And so
absolutely.
Yeah. Pardon me, didn't need that. But that's the bell to, I think, maybe wrap up the
Yeah, no problem.
Yeah, it was wonderful chatting with you, and thank you for sharing all that great information. And it's a dynamic, unique times we're living in.
Yeah. Well, thanks for asking me. I hope we've given you an insight as to what's happening here.
Yes.
It's certainly something that people are aware of, and we are not ignoring things here at all. And I think it's the only thing we can do at the moment to try and limit transmission, etc., and to save the burden on the rest of the system, because it's not going to take a big amount, from what I'm hearing from physicians, to absolutely tip us over the edge here.
Yeah. I know it's that vertical increase in
Yeah,
numbers that
yeah,
we're all
yeah,
concerned about.
yeah,
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 flattening the curves. Well, on a lighter note, I love the Stone Roses,
yeah.
so I might go listen to them for a bit of stress relief.
Very
Uh,
good.
but if that band was made up of a bunch of endodontists, they would have been the Pulp Stone Roses.
Very good. Well, that's a Sheffield band is pulp.
Oh yes, that's
Yeah.
right.
So there you go. Yeah.
Yeah. Well, it was fantastic. Thank you so much, David, and hopefully we'll see each other in San Diego at the TDO meeting.
Let's hope so, Joe. Let's hope it happens this year.
Yeah, yeah. We'll have to do either a soccer kick or an elbow shake. I guess a
Something like that.
handshake's
Yeah,
going.
yeah. Yeah.
Yeah. All right. Well, all the best.
Lovely. Thank you, Joel.
All
Cheers.
right. You're most
Bye-bye.
welcome.